Hey, good afternoon, everybody. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live from our Dolph Simons Family Studio. Delighted to be with you this afternoon. I want to welcome and thank the media and the community for joining our news conference today. You'll all have an opportunity to ask questions following some of our opening comments, and we really want to extend our appreciation that each of you are on the line today. I know some people have asked about recording this session. That's fine. We're giving permission for that. We'll also be recording it, and we'll send that link around to everybody afterwards. I want to make note of the chief medical officers from around our community who are joining this program today. First, Elizabeth Long, who's the acting chief medical officer at Olathe Medical Center. Raghu Adiga, the chief medical officer at Liberty Hospital. Larry Botts, the CMO at Advent Shawnee Mission. Peter Holt, who is the Vice President for Medical Affairs in the Central Region of St. Luke's Health System. Mark Steele, the Executive Chief Clinical Officer for Truman Medical Centers and University Health. James Stewart, who is the Chief Medical Officer, North Kansas City Hospital. And my friend and colleague here at KU, our VP of Performance Improvement, is David Wild. The public health directors today in the KC Metro released a call to action just a while back. In it, they focused on several recommendations meant to enable our community to decrease the rate of infection while also continuing to keep our economy open. This afternoon, we want to publicly support those public health directors and the recommendations and talk to you about the science behind those recommendations. As we have shared with you, our hospital beds are almost full, and in some places they are full, all across our city. Here at KU, we are deferring surgical cases so that we have the beds to accommodate all of our COVID-19 patients who are coming in, as well as our other routine patients who are coming into our hospital. We applaud the public health directors in making recommendations that will help decrease the rate of transmission, which is right now out of control. We have uncontrolled community-wide transmission of SARS-CoV-2, and that's reflected in some statistics we're going to share with you in just a moment. The rate of new cases is similar to the rate of hospitalizations, which you'll see in a moment. So if we can decrease new cases, we'll gain more hospital capacity that we take care of everyone with. You know, the struggle for us is real, and what will happen if COVID continues to climb exponentially in our area is soon we'll look like New York in the spring or El Paso right now. We'll run out of hospital beds, and not only will we not be able to take care of COVID-19 patients, we won't be able to take care of those who have a heart attack or stroke or have trouble breathing. We're at a crisis point, and how we react and pivot in that crisis point will define how our region does with respect to this surge of COVID-19. And it's never been more important than it is right now. As the weather gets colder and people move indoors, the chance of transmission grows. And the real struggle for us, and it is a struggle, is that everybody has a solid case of cows right now, COVID weariness syndrome. And we have it because we've been fighting this for a long time. But the good news is there is a light at the other end of the tunnel. So as we consider and try to implement these new ideas about restricting how we move about and how we conduct ourselves in public, remember, we do it with purpose. We do it not only to take care of each other and to take care of our community, and to make sure our hospitals are open to take care of you. We do it because there is real hope. For months, we've heard about vaccination develop or new drug therapy. Today, here at KU, we received our first shipment of monoclonal antibodies, and we're going to start giving them to patients who are diagnosed with COVID-19, who are not in the hospital, and essentially who are over 65, have a BMI of over 35, or may have significant chronic conditions like transplant. That's a major step to controlling this disease because, at least in the research data, monoclonal antibody therapy has decreased hospitalizations by 60 to 75%. That is a game changer. The second thing announced this week was Pfizer's vaccine for COVID-19. That too can be a game changer, and on the heels of that will be the one from Moderna, and then AstraZeneca, and then the one after that. These things are starting to be real, just as monoclonal antibody therapy is now real. But the battle against COVID will not wait for those things to arrive. The crisis is at our doorstep, and how we respond to it will define our trajectory and how we're able to take care of the patients and the people in our community. I want to turn first to David Wild. David is going to talk a little bit about the numbers that we're seeing in Kansas City and how the exponential rise in the caseload in Kansas City matches the rise in hospitalizations. Then we're going to turn to our CMOs and we're going to make comment on each of the 6 major points raised by the public health officers. David?
This is Chris Perryman. I don't know if you just couldn't see me, but I'm the CMO for St. Luke's and I'm on the call too.
I didn't see you, Chris. Thank you for joining. CMO from St. Luke's. Thank you, sir. Sorry about that. I would never intentionally do that to you. Okay, David, can you hear me?
I can. Can you hear me well?
We can. We got your first slide up.
Perfect. Great. So the message I think that we've been sharing widely across the metro is that this slide you see, or the slide that was there first, was showing cases across, new cases per day on average, 7-day rolling average being the red line across the metro. This is the slide or the image that you can all see in the star on a daily basis. It's not new. We all can appreciate the near vertical rise of cases really since the 27th of October. And the real important part of this is as this slide transitions to the next slide, you will see that the average here, the line that is plotted here, the number of hospitalized patients in a group of 6 hospitals across the metro, the shape of that curve looks nearly exactly the same. It might be delayed by a week or so, but it's exactly the same. So the continued increase in cases concerns us because it has always been shown to increase the number of patients in our hospitals. The following slide shows a snapshot from November 8th, just a single point, a day and time, that shows from about 12 hospitals from 8 health systems in town that are regularly sharing data on a daily basis. And there are a number of others participating in this conversation, but this is pretty much the majority of the hospital systems minus Prime and HCA. And again, they've been communicating with us and their pictures are very similar, just not able to share data on a daily basis. But this snapshot shows us that most of the hospital patients that are in hospital beds across the metro are non-COVID, the blue part of this pie. There are, though, a growing number of COVID positive patients taking up beds, the yellow slice. But more importantly, a small percentage of the beds in our region on the 8th were open and available for more patients who needed care. And that number was about 95 total in these 12 hospitals. The next slide shows you just a little bit of what this looks like on a rolling basis. And this slide requires some orientation, I realize. What you're looking at here is the daily picture. So the daily snapshot that I just showed for the 8th, but plotted over time. And so here, the gray section of this slide, the gray line at the top, for example, shows that for non-ICU beds, we have a little over 2,000 physical beds available in these 12 hospitals. The purple section is the number of those beds that could be staffed that shift. And you'll see that the number of those beds that can be staffed on a specific shift has gotten slightly higher as the week has gone on for a number of reasons, changing how we staff, using agency staff. And then the green portion of the slide shows the percentage and number of those beds that were available and staffable, so free, not having a patient in them on this given day. And you'll see that there are actually some days where we were negative. Cumulatively, there were more patients in the hospitals than there were beds available. And that's really driven by the fact that 3 or so systems have been holding patients in recovery rooms, in the perioperative space, or in emergency departments to be able to make sure we can care for everyone. But that's not not a process that can be sustained over the long run. The red line at the bottom is simply the number of COVID positive patients that were in these hospitals on a given day. You can see it climbing as the week went on. The next slide shows the same sort of picture, but looks at ICU beds. And you'll notice that there are fewer physical ICU beds across the metro, that we have the same sort of picture of most of them being staffed, but some that cannot be staffed. And you'll see that some of them are free, maybe about the same proportion or percentage, but still a number that is concerning as we look across the week. So Steve, I'll let you and the group take it from there.
Is go through each of our chief medical officers and ask them about one of the mandates. And we'll just start right at the top. I'm going to start with Raghu Adiga. First of all, Raghu, how many patients are in Liberty right now with COVID-19? Raghu, don't forget to unmute.
Apologize.
There you
Still
go.
learning.
Still learning. It's just a Zoom thing.
Yeah. Well, this morning we had 38 COVID patients in the hospital, and 3 of them were in ICU and 2 of them were intubated. And it keeps changing. Unfortunately, this is one of the highest numbers that we've had. We are tight.
Raghu, one of the things in the public health officer's recommendations is we have to continue a mask mandate. I think we know masks work, right?
Absolutely. I mean, it's a clear example how it works in the hospital. You talked about it a number of times before. I mean, we have 38 COVID patients in the hospital, and we know how to take care of them. We know how to take care of the people who take care of those patients. None of them are catching COVID from them. So if you do the things right, you wear your mask and follow the infection control principles, you can avoid catching it. So that's a clear example. Masks everywhere.
Masks work, you bet. Larry Botts, how are things over at Advent Shawnee Mission?
Well, we also have the highest number of patients that we've had throughout the pandemic. We're currently at 33 patients. We have 6 patients in the ICU with 3 currently on ventilators. So we're rapidly approaching our capacity.
Talk to us a little bit. You know, the second recommendation from the public health officers is that we had to limit social or in-person gatherings to further reduce the community spread. Help us know, why is that effective?
Well, the most effective thing to do is obviously be able to socially distance and with masks. And when you are gathering with a larger group, particularly as the weather gets colder and we're moving indoors, those 2 things become more and more difficult. Masking to protect each other, and then social distancing to make sure that we are not passing that virus from one person to another. Those are the situations that are most likely to cause spread of the virus rather quickly.
Happening over at Advent Shawnee Mission these days?
I think I lost you, Steve.
Oh, that's okay. I'll come back. Peter Holt.
All right.
How are the numbers at St. Luke's Health System? Either you or Chris.
Yes, Steve, I'll give you the St. Luke's Platte numbers, and I'll defer to Chris to give you the system numbers if he has them. We were at a 52 on the plaza this morning, and we had 20 people in our intensive care unit. Chris, I think, may have the numbers for the system. I would be remembering off the top of my head if he doesn't. But Chris, do you have the numbers for the system?
I certainly do. I got the number just before the call. 164 with 47 in the ICU. You're right. And right now, St. Luke's has 59. But you know, we have the 4 metro hospitals and our community access hospital. So our numbers are growing as everyone else's.
Chris, have there been any important changes with you or Peter in your approach to surgery so far?
Well, you know, yes, the answer is we have a daily program where we look at how the census is, the capacity of beds, COVID beds, non-COVID beds, how we're going to deal with surgeries. We're not doing as many elective surgeries, and Peter can address how we do the majority of our surgery at St. Luke's Hospital. But yes, we look at the surgery schedule, we talk to the surgeons, we look at the cases, and we try to make a decision based on what's best for the patient. But there's no question if people aren't going to do the fundamentals of infection prevention, it's going to impact people getting the surgery they need.
And how's the staffing at St. Luke's right now?
Well, right now we're okay, but that's one of the worries, because if you get a nurse or an employee who gets exposed, they're out of work. And then that cuts down the ability to staff the units and cover them like you want to.
Larry Botts, I'm back to you now. Larry, how's the staffing holding up at Advent Shawnee Mission so far? I'm not hearing from Larry, so I'm going to jump to Mark Steele. Mark, the fourth recommendation is to place further limitations on outdoor and indoor entertainment and recreational venues. Talk to us a little bit about the science behind that, and also, how are your numbers today?
Yeah, so Steve, our numbers today, we were this morning at 39, which is just one shy of our peak. We have 8 in the ICU, and fortunately, we currently don't have any patients on ventilators. And that item is really very similar to all the other items in that it's all about social distancing, how many people you have in a particular environment, and then, of course, the masking is also very important.
Indeed, thank you. And how's the staffing doing at Truman?
We actually, it's up and down, but it's a struggle sometimes every day. And we particularly are having challenges with staffing in our ICU, but also intermittently in other areas. And so that's a big concern for us.
Yep, same here. Okay, so I'm going to turn now to James Stewart, who's the Chief Medical Officer at North Kansas City. Let us know your numbers.
Currently, we've got 61 active patients, 16 are in the ICU, and 7 are on ventilators, which is near our peak.
Okay, and how's staffing?
The staffing's tough. The ICU staffing is tough. The rest of the staffing is not too bad. The problem is we have employees every day who test positive, and they're not getting it here, they're getting it in the community, and that's why it's important to control the spread in the community, because that's where people are getting infected.
Indeed. So, the fifth recommendation from the public health officials was to place a requirement on recreation and youth sports events to limit the number of attendees and ensure social distancing. What do you think?
Well, I think that that's important, and the problem is not the events themselves, it's the behavior at the events. When people start yelling and screaming and they're right next to each other, it's difficult to socially distance. Even if they're wearing masks, sometimes we've all seen people who don't wear their mask properly, so it's just a hot spot for spread of the disease.
Yeah, I think that's right. We heard from Rex Archer today that, the Chiefs have an Arrowhead, and you think, oh gosh, we should stop that. But he's pointed out to us that they keep people 9 or 10 feet apart, or groups of folks 9 or 10 feet apart, and that that because they are able to do that and enforce mask wearing, they don't have a documented case of spread yet at Arrowhead, which is a remarkable statement. We also know that when we can de-densify a school campus, or the work we've done in Lawrence, the rate of transmission on the campus in Lawrence is about half that of the community. So, when you can do this right, but you got to really commit to these principles. Elizabeth, down in Olathe, how are things with you all?
We're doing okay. We've basically doubled our census and our COVID positive patients over the last 2 weeks. We are currently at 27 positive patients with 7 in the ICU and 5 ventilators and 9 PUIs. But our census is definitely, we are bulging at the seams. We have 151 for our census, and for staff beds, we have 158. So we just have a few beds open at this time.
And I think that's all of our concerns, because we know that as this transmission continues to spread, those things are going to become harder and harder. Our numbers at KU, David, do you have those right now?
We had been at noon, the last I saw, we were back up at 70 acute positives, and we were 104 total, meaning that there were 34 patients who were here for COVID disease, but were no longer on isolation. So that's 104 patients that were taking beds today that would not have been taking beds if it weren't for COVID.
So, and I think we still have some staffing concerns.
We've been lucky to find ways to staff more beds than we physically have, but that doesn't mean it's not been without challenges and that we're not concerned about it.
So if we're full and everybody's almost full, then here's our dilemma, right? When you looked at that graph that David showed you a little while ago, it showed that Kansas City is now up to 1,000 or 1,200 for its rolling 7-day average. But today's hospital census reflects conditions about 7 to 10 days ago, which is when we were in the 300 to 600 range, and we're twice that now. So if we take this total COVID census and we double it, we got no beds. And in addition, it means that patients who are having a heart attack or stroke or something else are going to have a hard time finding a bed. That's the place Kansas City finds itself, and that's why, as a group of chief medical officers, we fully support the recommendations of our public health officials and stand with them in recommending this to our community to keep each other safe. Because we have to do that, or we're going to have a real crisis on our hands. So with those thoughts, let's see if there are questions from reporters.
Steve, this is
Abby
Peter.
Dodge from KCTV5. This is Abby.
Hey, Abby, let me get back to Peter Holt, who I think he was a CMO over at St. Luke's, or the whatever that right term phrase is there, Peter. Sorry, the vice president for medical affairs. What was your question or statement?
Steve, I thought it might be pertinent to point out that the things that we were concerned about back in March and April, when we were seeing the start of the pandemic, was really not related to capacities in the hospital, although we were worried about what could happen to capacity. As you all will recall, our worries were about would we have enough PPE or personal protective equipment, and would our supply lines allow us to have enough hand sanitizer and supplies in the operating rooms. The problems now, of course, are we've gotten all of those problems resolved. We have plenty of PPE, we have plenty of supplies. What we no longer have, because of the community spread, is the capacity in the hospitals to manage these patients.
Well, I think that's right, Peter, and thank you for pointing that out. That is something we have talked about on our program and others with our CMOs, is that really it was a PPE question and trying to rework our flows, and we were afraid of this huge surge that never really came, but it gave us the chance to build up PPE supplies. Today, we have the supplies. What we don't have is enough beds because the surge is real. Let's return to TV5 now. I think you had a question.
Yeah, this is Abby Dodge from KCTV5. We know this incubation period with COVID-19 is about 2 weeks. If we look back on the calendar 2 weeks ago, that was Halloween. I mean, does that have any sort of connection to what we're seeing right now?
I think that's a great question, Abby. Thank you for asking that, because absolutely. We think that when people go inside or they have events when they party, then that is going to spread the virus. We know that homes are one of the places where people are spreading because they're having parties inside as the weather has turned colder. We are frightened about what's going to happen with Thanksgiving and Christmas unless that behavior changes. Raghuda Adiga is the Chief Medical Officer at Liberty. Raghuda, you're an infectious disease doctor. What do you think about the effect of Halloween?
Yeah, I do think it had an impact, even though it's not entirely purely related to that. I mean, the curve was already starting to go up. It just added to the problems. I think people, as you mentioned, indoor gatherings are the biggest driver of this. Even small gatherings that's happening, I think, is adding to this. No question.
Yeah, totally agree. Other questions?
Chris here, Fox 4. You mentioned in an interview, KU Health call you mentioned in a KU Health call you did recently that the rise that we were seeing was due to people being largely irresponsible with how they're handling it, not wearing masks, being out in public. What is, in a one-sentence form, if you could, your recommendation on how to help curb that?
Yeah, follow the rules of infection control. They go with you wherever you go. You just got to take them with you. And they don't change because you're a Republican or a Democrat. They don't change because you're young or old or black or white. They don't change because you're in Kansas or Missouri. They don't change because the coronavirus doesn't discriminate. It doesn't care who you are, how much money you make, or where you live. Coronavirus is looking for a host. And if you don't follow the rules of infection control, with widespread community disease that we see today, coronavirus is going to find you. And if it finds you, you have a good chance of developing all the symptoms of COVID-19. That can bring you into the hospital. So the real key to this is bending the curve by following the rules of infection control. We'll come back to that at the very end because we've got a riddle for everybody.
Steve, could I ask, just comment on that too?
Please, Chris.
Every physician who sees a patient in your office, I tell every patient to do those things. Wear a mask, socially distance, wash your hands. And I think it's just not up to physicians in the medical community. I think it's up to newscasters, reporters, public officials, your friends. You can tell everybody that message. It doesn't have to be an urgent message. It's something we should be practicing in our daily lives. So I think one of the things that helped in the beginning, back in the spring, people got into it. Behavior was good because everybody en masse kind of bought into it. As things got less severe, people got lax. And I think if you have a friend or a relative that you know is not following these guidelines, it's in your best interest, and especially those of your vulnerable relatives, for them to hear that message. Please mask.
Thanks, Chris. So true, because we know that makes a difference. Go ahead.
Hey, Steve, I have a quick comment. I think that one thing that I would absolutely caution people about are these casual gatherings at homes. And I think there's a certain comfort level that friends, neighbors, relatives you haven't seen in a while, that bringing them into your home, that everything will be okay. And people have to not forget that 40 to 50% of folks with coronavirus have no symptoms. So they may look perfectly fine, but unknowingly bring that into one of these gatherings. And we know that's occurring. And then all of a sudden you have a whole series of new cases. And ultimately, if you have somebody who is high risk or older in age, and then they get it, then we end up seeing hospitalizations and unfortunately deaths. So just caution people about that.
Well said. Thank you. Other thoughts from one of our CMOs around that?
Dr. Stikes, this is Michael Mahoney from Channel 9. Can you hear me?
Yes, sir.
I did not hear any discussion about the other recommendation to perhaps close bars and restaurants at 10 p.m. or else have them make other implementations about how they are handling their business.
Yeah, so we'll see what our other CMOs. Here's my stand on that. We support the public health officers and all the things they're trying to do, and I think what they're concerned about is that people who are at bars or restaurants after 10 tend to maybe behave a little less responsibly, and so they're trying to put that time limit on. We see that going on in a lot of communities, and people do believe it curbs the behavior. Here's my point. Behavior matters. And whatever setting you're in, behavior matters. And that's what's going to bend the curve. And so if in the public health officer's view, behavior begins to change after 10 o'clock at night and encourages more spread, then I'm going to support that recommendation. Other CMOs?
Yeah, I think it's important to realize that the virus doesn't have a watch. There's nothing magic about 10 o'clock, but it's the behaviors that change the longer they're in these settings that makes the difference.
Yeah, well said, Jim. Thank you. Raghu, any thoughts you want to add to that?
And I would completely echo.
Elizabeth. Go ahead, Elizabeth.
Oh, I'm sorry. I would completely echo that I wholeheartedly don't think the time of day matters. It is the behavior that matters. As far as 10 o'clock, you're not safer at 9:55 than you are at 10:05. So it's really the masking, the staying apart, and doing those pillars of infection control that should be the priority.
All the time, every minute, every day. That's what'll bend this curve. And just remember, the reason we're sounding this warning and showing our support for the public health officers who have worked incredibly hard throughout this crisis, right? The reason we're trying to show this is because we think we're in trouble. All you have to do is look at the curve. And today's number, we do this call a lot, and today is our highest number we've reached so far. We're at 432. And so we've broken 400, and we're rising. And so we've been doing these calls since the middle of March, and what we're seeing now is what we have always been afraid of. And we're really afraid because we're stretching our beds. We don't have our staff. Our staff are getting sick. They're out in the community. They get COVID. They get an exposure. And yet, folks are going to need care. And if you step back and you say, why is our death rate, our death rate now in hospitalizations runs around 7% by and large. And why is that so much lower than it was at the beginning of the crisis, say in New York City? When it was higher, like 20 or 30%, or in Italy when it was 40%, or whatever it may have been. The reason is that when you overwhelm your staff, you can't take as good a care of people. And then your staff gets sick, and then pretty soon your ICU ratios, instead of being 1-to-1 or 2-to-1, which is what we all want those to be, go up because we don't have any staff. And so what happens then to care? We don't want to see that story. We don't want to have a story where a trauma becomes a place looking, an ambulance looking for a place to land. We don't want to see a time when a heart attack can't get to the cath lab right away. But COVID can do that to us because it's done that to other communities. And the only way to change it is to follow the rules of infection control. Other questions?
Where we stand right now, what would you say is the more imminent threat of the two? The fact that we have a shortage of beds because we have so many new cases, or the fact that staff is sick and because of that, there aren't as many staffed beds available, backed by numbers?
Yeah, that's a great question. Let me turn to some of our colleagues out there. Larry, what would you say it is at Shawnee Mission?
Well, it's certainly a combination of both. We are having difficulties from a staffing standpoint because of COVID and having to quarantine and having to stay home. And when the difference between COVID and say other respiratory illnesses is when you get COVID, you're at home for 10 days. If you have a cold and another respiratory illness, that may be 3 or 4 days and you're back, and we're not able to do that at this point. So I think it's certainly a combination of those two things, but our staffing issue is the biggest one that we're dealing with now.
Chris, what do you think with St. Luke's? What would you say your bigger challenge is? Don't forget to hit your unmute button, Chris.
Yeah, well, I agree with what everybody's saying, and it's a day-to-day thing and a week-by-week thing, beds and staff. But I think the thing we're challenged right now with mainly is making sure that we have the capacity to bed with beds to meet the need. I mean, like I said, we've got 164 COVID positive patients, and I think it's something that it's a dual threat at every institution. But I remind everybody again, the key thing is to decrease that demand for the hospital beds by doing the infection prevention thing so people don't wind up in the hospital.
I saw the dean from University of Texas, El Paso was on a town hall with the university here yesterday. And he talked about the 4 mobile morgue units they brought into El Paso, and he talked about the multiple tents they brought in, trying to bring staff in from all over the country to help take care of patients. That's a story of being overwhelmed. And the way you don't do that is you have to follow the rules of infection prevention and control. So, next question.
Emma James with 41 Action News. Do you have any detail about age groups and which age group right now we're seeing as having the most cases?
You bet. Well, let's check and see what others are experiencing. Raghu, what's it like up in Liberty?
The last time I looked at it, this is about a couple of weeks ago, our majority of the population was above 50. So you can look at 50 to 65 and above 65. So at that time, we had about, I think, 30% above 65, and above 50 was well over 60 to 70%. So we had a small number less than 50 age. So the population, I think about 30% of our population came from long-term care facilities, and vast majority of them are elderly. And from the community, they tend to be a lot younger with medical problems, especially obesity and diabetes and other medical problems. They tend to be a lot younger. So I can't give you the exact number right now, but that's how it's been at Liberty.
David Wild, here at KU, we saw an older population early on, and then our age definitely dipped. Talk to us a little bit about some of those statistics.
Sure, Steve. So early on in the pandemic, the patients that we saw being admitted to the hospital were, at least in the months of March and April, averaged above 64, 65 years of age. Over the rest of the pandemic, that number has decreased. So we are now averaging around 54 or 55 years of age for the totality of the patients admitted to the hospital. That doesn't mean that we haven't seen young patients or older patients. So our youngest patient has been less than a year old. And we've had 98 or 99 years old that I know of in the hospital, and everything in between. We've had 9-year-olds in the ICU. We've had high school athletes who had significant complications like heart failure. The big picture, I think, though, is if the question is related to where are we seeing spread, we are seeing transmission in the community based on the numbers that the state and local counties submit. That is really every age range. There is no one age group, maybe with the exception of 20 to 30-year-olds, that is transmitting or becoming infected at a higher rate than any other.
Yeah, such a
Steve,
concern.
this is Peter.
Pete, please, Peter.
Yeah, I would want to point out something I think is extremely germane to this conversation, and that is that we at St. Luke's have seen the same trend that you have at KU, with initially starting with an older population, and our population has gotten younger. But the point that I think is really pertinent to that is if you look at where the most restricted regulations are in the community right now, it's in nursing homes and retirement communities where older people live, because they have recognized the significant risk that you have. So while we have become slightly more liberal in terms of things like visitation, where we're now allowing visitors at the hospital, they're still not allowing visitors in most long-term care, if not all long-term care facilities and retirement communities. So they have really maintained the principles of infection control to a much more, a greater extreme than we have in the community. And that probably accounts for why we're seeing a younger population. And again, points to this issue of we know it will work if we do it.
Yeah, that's a great point. Thank you. Mark Steele, anything else you want to add to that?
No, I mean, we've seen very similar things here at Truman. Our average age now is running kind of in the low 50s. But clearly, I mean, the majority of our patients are 50 or older who are in the hospital.
Next question from our media colleagues. Okay, Jill, were there any community questions?
I think someone was getting ready to ask.
Go for it.
I do have a follow-up on the demographics. We do have a community question asking, are all these people have comorbidities?
You bet. You know, that's a funny question, right? Because you have to define what a comorbidity is. You know, it's popular to say, gosh, the people who are just dying of COVID are very unusual. But the truth is, that's the same case with pneumonia or influenza or any other disease process. The problem with COVID is that some of these, quote, comorbidities are not so morbid, but you got them. You know, a little bit of high blood pressure, you're a little overweight, a little bit of diabetes, and pretty soon you just need one of them and your morbidity begins to go up pretty rapidly. Age over 50, morbidity starts to take off. I'm 60, I'm like in the high risk category. So I think that it doesn't take a lot of morbidity to be considered comorbid. And I think that's one of the things that scares all of us. Peter, you do a lot of you're a geriatric specialist, and talk to us a little bit though, because I think you've seen patients who are both young and old, healthier and sicker. To start.
Yeah, I would, and I do have the opportunity, as you know, Steve, to be the medical director of a nursing home and a retirement community. And I have to say that I think those patients that I take care of that are community dwelling have tended to be much less conscientious of the infection control pillars as those that we have that are in retirement communities. They have tended to be much more, much more rigid and follow those guidelines much more closely. And I'm sure part of that has been because we have emphasized a higher mortality rate amongst those that are older. But I think we all in our hospitals can tell of stories of young people, sometimes very young people. We've had people here at St. Luke's in their 20s that have been on ventilators for a prolonged period of time. So even though we can talk about the higher risk in the elderly population, it is not without risk in a younger population. And those people are coming from the community where they're getting greater exposure.
Yeah, that's a great point. And the other thing, just to add, and Larry, you're an ICU pulmonary guy like me. I think you'd probably reflect on this as well. But just because you don't die doesn't mean you're not wounded. and you could be wounded for a very long time, especially with the underlying lung disease and heart disease. Have you seen some of that at Advent as well?
Absolutely, and you're right. Even those people who survive, when you spend a long period of time in the hospital, a long period of time on a ventilator in the ICU, it takes a great toll on. It really impacts your life for a long period of time. Sometimes forever. So it is. It is not just. The fact that people die, but people are very, very ill, and that is a long-term problem for those individuals.
Yeah, and that's the struggle. And people, we haven't talked about that much. We've talked so much about the death rate. We haven't talked about this morbidity rate, which is extraordinarily high. And people still want to make this to be influenza, and it's like, you got to be kidding me. We have never had a public health crisis around influenza that even becomes close to this. We've never had to have, as they do in El Paso, portable morgue trucks come down because of influenza. I mean, this is not since the 1918 pandemic. Let me qualify it like that, but certainly nothing in recent memory. Jill, other questions in the community?
Yeah, we do. We have quite a few, and some of them I think are germane. One of the questions from M is, are the rural communities with reduced space, are they what is causing the urban crush?
Oh, that's a great question. Is this coming because of rural space? And what we can say is, at least at KU, 70% of our patients are from the metropolitan area, not from a rural community. 30% come from outside our area. And yes, the rural areas do have a significant crush. But don't try to persuade yourself that that's the only reason we're in trouble. It is completely untrue. We're in trouble because we're in trouble locally, we're in trouble regionally, we're in trouble throughout the Midwestern part of the United States, because the whole Midwest is considered a significant hotspot. And I think that it would be unfair to characterize this as a rural-only disease. We are all in this together. Elizabeth, you at Olathe, you guys kind of border both rural and urban, and in your setting, are you seeing people from both inside Olathe and outside?
We are really seeing more people just from our own catchment area. We haven't had a lot of transfers in from the rural area, maybe about 5% for us.
And Raghu, how about up in Liberty?
Yeah, as you mentioned, I think even at Liberty, we have a combination of both. We see anywhere from 25 to 30% of our patients coming from rural areas up north. Part of the problem also is because most of the hospitals up north there are much smaller, and so they do not have all the capabilities to provide care. So that's one of the reasons why we get transferred here, critical care beds or specialty consultations or specialty drugs being available. So some of those reasons we do see those patients, but you're exactly right. The problem is not rural or urban, it's everywhere.
And Jim Stewart, I'm guessing the same thing is going to be holding true at North Kansas City.
Yeah, absolutely. And part of the problem here recently is that the smaller communities wanting to transfer people in, it's hard to get them here because there's no place to put them. When we're out of ICU beds, and that's what they need, we can't help them.
All right.
Cindy said she had a family in rural part of Kansas that needed to go to the hospital. She was non-COVID patient. They sent her out of state. She goes, why is that happening?
Yeah, that we're seeing that, and Raghu, you can tell your story you told this morning in just a minute. Yeah, when you don't have beds, you don't have beds, and so then you start looking around. And I know here at KU we've had calls, David, go through it. I think you've had calls from Arkansas and where else?
Yeah, so we normally get calls from maybe our normal area would be the western half of Missouri and maybe the eastern 2/3 of Kansas, and we have now been receiving calls from far western Kansas, from all parts of Missouri, and in the last couple of weeks from Nebraska, Iowa, Texas, Arkansas,
Oklahoma.
I think those are the states that have had multiple calls. Oklahoma, yes, those are the states with multiple calls.
So I mean, we're just seeing it from everywhere.
And I think that the question of
Go.
Yeah, the question about are those patients COVID patients that are being called, or are they patients with other problems? They are patients with all sorts of problems. So the story of a Kansas family member having to be transferred out does not surprise me in the least, because everywhere is fighting the same battle, everywhere within hours of us.
And Raghu, you guys had to take a patient that had flown over all the major core hospitals and had to go north from I think it was southwestern Kansas.
Yeah, we had not had this experience before. We get patients flown in from up north, not from down south. So last night was a strange experience being called from a small community at the Oklahoma-Kansas border and needed an intensive care for a non-COVID patient. And it's 6 hours by ambulance, and that we did not feel it would be safe. So they airlifted the patient to our hospital. So yes, it is strange, and it is happening both COVID and non-COVID.
Yeah, so this is not a Kansas issue or a Missouri issue. This is a we issue. We're all in this one together. 2 more questions, Jill.
Right. Michael wants to know, at the start of the pandemic, nurses and doctors from here traveled to support the surge in New York City and other places. Why don't other cities come and help us now?
Yeah, one of our struggles is that everybody's on fire. And it was one thing when you had Kansas or you had, say New York and Seattle. The problem that we're running into today is that so many major cities are struggling with this. And, Chicago just put in another complete lockdown because of their rapid rise. New York City is contemplating canceling all schools and another lockdown because of their rapid rise. We're all in this one again, and it's going to be much harder to find shared resources, whether it's people or equipment or PPE now, because everybody's struggling with this surge. And, we all predicted it, right? We knew this was coming when the weather got cold. If folks got tired of wearing their masks and just wanted to have parties and have people over and move inside and do those things, then that was going to be a danger zone. And that's exactly where we are.
And last question, Sandy asked, the call to action states that if numbers don't improve, additional action may be warranted. She's wanting to know, how will you know? How are you going to measure that, and how are we going to know?
That's a great question. Chris, what would you say from St. Luke's perspective, or Peter, what do you think will be the sign that says to us we're going to have to take more steps?
Well, I won't speak first, and I'll let Peter. But number one, it's going to do with bed capacity and staff capacity, as we've already referred to. And the other thing is all hospital transfer teams that are traditionally taking patients from outside hospitals, those have been affected. And it's gotten so bad now it's even affected our city and our metro areas ambulance services. So I'd have to say that really is going to be the ongoing struggle of when we have to take stricter action is when we don't have bed capacity.
Sounds like we're not that far. Peter, what are your thoughts?
Steve, I think it will be an issue of when we go back to the graphs that you and David showed earlier, when that peak is over and we start to see flattening and the numbers go down, we'll know we're okay. If we continue to see those numbers go up, we know we have to ratchet down just a little bit harder each time those numbers go up.
Yeah. Jim Stewart, how about what's your thought from North Kansas City?
Unmute.
He may be muted. There he is. Jim?
There we go. No, I think that it's just like everybody else has said, that it's a bed capacity and a staffing capacity, and we are able to do that now, but if it gets much worse, we just don't know.
Raghu?
Yeah, if you're asking me what could be worse than this, what could be worse than this is asking our nurses to do a lot more than what they're already doing. You're asking them to, take care of a lot more patients than they can possibly do. That's worse. And another worst thing is what kind of procedures are you going to be putting off? I mean, that has such an impact on community's health, and there is only so much you can put off. And if you start putting off more serious surgeries, that's a lot worse. So that's what we want to avoid, and that would be the threshold you're looking at.
Mark Steele.
Yeah, not much to add, although just to extend on that thought is that not only significantly reducing our surgeries, but also, once again, a lot of our medical visits and whatnot, because our only off-ramp in terms of staffing is pulling in whatever nursing resources we have from those outpatient areas, from our ORs, or from all the nurses who are not currently doing clinical work. But after you exhaust that and spaces to put people, you've got nowhere to go.
Yeah, that's so true, isn't it? Larry Botts? Don't forget to unmute, Larry.
Sorry. Yes, I'm here now. Sorry. Yes, I don't have a whole lot more to add. I think everybody's covered it very well. I mean, we only have so many levers to pull to be able to increase our capacity, and we just have to do that a step at a time.
Yeah, I think that's right. Elizabeth, Olathe?
I too don't have a whole lot to add, although I've been thoroughly impressed with the cohesiveness of the medical community throughout this entire epidemic and pandemic. And I think that we have tried to address the issues as a community, and that continues to work very well for us.
I think you're right. David Wild.
Yeah, so for a guy who's all about the numbers and the data, I think we've hit on it. The things that will tell us that we need to do more or that it's okay to do less will be the same things that we're sharing with you today. How are we doing on hospital capacity? How is the rate of community spread changing in our area? Are we able to staff with healthcare workers the resources, the physical resources, meaning whatever beds and clinics and hospitals and emergency departments we have, whether they be those that we have right now or whether they're some sort of field hospital or tent option, if those things need to be on the table. And I think that we'll have a good sense. I mean, we'll know. Look around you as to how many people now know someone who's positive or sick right now, and how many people are hearing that staffing in whatever their industry is becomes a problem as more people are quarantined or ill.
Thank you, David. You know, to all of our listeners right now, thank you for joining us. I said I would end with a riddle, and here's my riddle. Name the most dangerous spot for COVID in every city in the United States, which is also the safest spot for COVID in every city in the United States. Where is that place? The answer is, it's right here at your hospital. The COVID wards inside our hospitals have by far the greatest congregation of COVID positive patients of anywhere, right? That's a really big spot. It's a really hot spot. How much disease spread do we see inside hospitals from patients to staff? And the answer is almost zero. And why is that? Because our staff are great and they do a great job following the rules of infection control. The rules bend the curve to almost zero every moment of every day inside the greatest hot zones in every part of the United States. We can do this because we do this. The other choice is to let exponential growth go wild, to try and go out there and grab herd immunity. And that's just going to hurt people. Because we're already experiencing it. We're already having to delay surgeries. We're already having to overwhelm our staff. And I tell you, our nurses, they are a resilient, terrific group. And they get tired. It's going to be tough. We have to bend this curve. We can bend this curve, and we know how to bend the curve. Just remember the rules of infection control. And the way we always end our program every morning, there's still no place like home. Thank you all for being with us today.